Yes, thank you for introduction and greeting and good evening to you all, council and member of the network, also the guests who are joining this event. Let me introduce my name first. My name is Ro Chun Ieng. I'm the former head of the Health Economic and Financing Bureau of the Department of Planning, Ministry of Health Cambodia. And then I'm moving to be a Deputy Director of the Payment Certification Agency. Mainly having seen the vision and the mission of the AeHIN, it's my pleasure to share with you the overall overview of the social health protection, with focusing on the application tool used for managing health equity fund in Cambodia. Can you move to next slide? Who's managing the slide? I do myself or? So during the presentation, I will briefly talk about the overview of social health protection in Cambodia, then moving directly to the patient management and registration system, and deeper to the PMRS specific role and its function and process. Then its accomplishment. Lastly, we'll inform you about the information that anyone can directly contact to our technical staff about the PMRF. Let me start with the social health protection in Cambodia. Have you seen on the screen, there are a few schemes which provide social health protection for specific targeted people. May I start with the social health insurance for the formal private sector and the public formal sector, which I refer to the civil servant, veteran, so on and so forth. And then the Health Equity Fund scheme, which later on you will see deeper who are the targeted people for the Health Equity Fund. And we have the program, what we call the Untitled Foundation. I might think that most of people here are heard about the Untitled Hospital, which founded by the Dr. Bitrichner, originated from the Swiss country. Now he passed away. And other civil society organization scheme who are supporting a different benefit package for specific their own target population. Next, please. I got this information from a paper which produced by the people at the National Council for Social Protection. So far, the coverage of the social health protection cover less than 50% of the total population in Cambodia. If you see on this graph, I wonder whether you see my cursor or not. And the blue one is referred to the Health Equity Fund. This is the biggest pooling in with regard to social health protection in Cambodia. It covers nearly 20%. And then the social health insurance by the National Social Security Fund, which is green color. This one is the second largest pool, which cover around 10% of the total population. and the rest are with smaller and smaller coverage. Totally, it's less than 50% of the total population in Cambodia. Start the future. Yes, we pick up only one scheme to share with you today. It's about the Health Equity Fund. I assume that most of us here could have been heard about the Health Equity Fund in Cambodia, because many papers produced, or many professor or university or NGO have conducted study about the Health Equity Fund. So this is one of the mechanism to support the poor, and originally, and then expand to cover informal worker to access to public health services. So this is the key features of the Health Equity Fund. We have two targeted population covered by the Health Equity Fund. One is poor people. Second is informal worker. The benefit provided by this Health Equity Fund are health services plus associated costs conditionally for the poor, and only health services for informal worker. About the provider payment mechanism, we implement the lump sum case base for both poor and informal worker. The funding to support this Health Equity Fund implementation is through pool fund with the joint donor and the government counterpart fund, through a project we call Health Equity and Quality Improvement Project. In short, we call AeHIN. This is for the poor, while the funding for the informal worker are fully supported by the government or national budget. The stakeholder who play a role in the implementation of a Health Equity Fund mainly are Ministry of Health, MOH, Ministry of Planning, MOP, OD, Operational District, and the health facility. I refer to health facility, refer to health center and hospital who are providing health services. And Health Equity Fund promoter, HEFP, Health Financing Steering Committee that create each at the subnational level, at the provincial level and district level, which consists of inter-department and inter-bureau at the operation at the district level. And lastly is the Payment Certification Agency, PCA, the place where we are working. While for the informal worker, MOH, National Health Social Security Fund, who are issued the card for informal worker, operational district, health facility, health financing district, and PCA. So far, the coverage of the Health Equity Fund for the poor is more than 3 million people, while the informal worker are less than 10,000 coverage of people. The application tool we use to manage Health Equity Fund is PMRS, no? Patient Management and Registration System. So, can we move on, please? Yes. What is PMRS? I'm sure that from so far, from the previous event, most of you have aware of what is patient management and registration. So I just reiterate. It is a web-based application that been used by the all public health facility to manage data health facility data, including Health Equity Fund data, both utilization and financial information. The main PMRS function is to record individual patient profile. As you know, the profile of the patient should be name, age, sex, address, so on and so forth. Second is a clinical visit. What are the diagnoses? What are the illness of the patient? Lastly is the claiming for the reimbursement from Health Equity Fund. Yes, go on. These are the module within the PMRS system. We have the facility registration module, which refer to the module that register facility. When I talk about the health facility, it refers to referral hospital and health center and national health center, hospital. We have the module for clerk to do their job. We have the module on Health Equity Fund to operate or to manage information about the Health Equity Fund. We have the module for cashier to manage the fund. We have the module for the reporting. This is to produce the report for our client to require the information about the Health Equity Fund. And the module for monitoring and the module for management. This is specifically for Health Equity Fund function within the PMRS. There is a function to manage the advanced funding at the hospital. There is a module function to manage for patient benefit of Health Equity Fund. The function for Health Equity Fund reimbursement, which refer to health facility invoice submission. Because each facility, they have the function to submit the invoice. They have a function for PCA staff according to level. For example, the Health Equity Fund technical officer who doing the invoice claim review, verify, and certify. And then we have the function for PCA refer to the role of finance who produce the certified invoice and submission for reimbursement from the Department of Budget and Finance, Ministry of Health to the facility. We have the function for Department of Budget and Finance to review and make the reimbursement to facility. We have the function to auto fraud management. So far, we have produced two functions, what we call the prevention and fraud prevention and fraud detection. And lastly, the function for monitoring that we can do for the document review, household interview, and bedside and the report. This is a PMRS specific role who have a user in the PMRS at hospital and health. We have hospital management. This is for hospital director or management team who do the register for the facility in PMRS, and also the one who are finally submission of the invoice to the PCA. We have the hospital clerk who do the patient registration, admission, discharge, and transfer. We have the user for the accountant of the hospital who doing the closing period, produce invoice, manage cash advance and control. We have the function for role of the cashier who do the payment for non-medical benefit to the it can be clumsy for cashier and equity fund because some hospital they only use a cashier to collect the money from user fee, also payment the non-medical benefit to the health equity fund patient. So in this presentation we separate between cashier and the health equity fund officer. Yeah, and then we have a role of the OD, operational district director, who do the health facility, who do their health facility under their supervision in the PMRS system. They are the one who do the final submission of the invoice from the health center under their responsibility. We have the OD accountant who do the closing period and invoice generation from the health center to submit for approval from the OD director. We have health center module, which is doing the patient registration, admission, discharge, and also somehow provide non-medical management, which is specifically for the delivery case. Can move on. This is a role for central level, which refer to PCA and Department of Budget and Finance. The PCA, upon receiving the invoice submission from health facility, our TO, technical executive officer, they do the verify the invoice and then certify and submit to the PCA finance for generate all the invoice and produce the invoice for the management to approve and submit to the Department of Budget and Finance. And last role is the role of the Budget and Finance Department. They do the review invoice that they receive from the PCA and they verify, and then they set that for reimbursement and inform to the bank to process for payment or reimbursement to the health facility directly. This is a PMRS function in hospital. We have the hospital administration, which refer to the management team who doing the health facility register in the PMRS, mean their own facility. For example, if they are the national hospital, director hospital, they are doing the register of their own national hospital into the PMRS. And they are manage overall the function of the PMRS function within their own hospital. They do the invoice submission, final invoice submission to the PCA after they receive the invoice from the accountant. Yeah. And the role of the accountant is doing the closing period for the claiming time. They control the cash advance. You might wonder what is cash advance happen in hospital. The cash advance here is refer to the fund which provide in advance from MOA to cover the non-medical costs. So hospital receive this cash advance. So this cash advance are managed directly by the accountant. The accountant also do the invoice generation and submit to the director. Function of the cashier, what do they do? they collect the payment from user charge. They certify the replenishment request and manage the advance, because the cashier in hospital, we allow to have advance that money in hand to support for providing the non-medical cost to the inpatient, like food or travel allowance or funeral contribution. The function for Health Equity Fund officer is mainly for discharge the case, which according to ICD-10 diagnosis, they are doing the completion of the case. That means the admit and discharge. They can switch the case whether from OPD to IPD or from other social health protection scheme to Health Equity Fund scheme. They manage the non-medical payment. They do the direct giving money to the inpatient, to patient who stay in hospital for their food or transport of funeral, and they keep tracking the expense of the advance payment in the PMRS system. Lastly, clerk, they do the patient register, patient search, and case admission. Patient search, this means some people might come with the DAO card or with some information. Then we can explore or search for the patient in our PMRS system. Next, please. This is just a picture of the official patient flow in hospital, where it starts from the walking in, then reach the triage at the first stage. All the patients need to meet the triage people, the place where we distribute or divide the patient to the certain department. For example, they meet the people at the triage. They do the first medical health check, like blood pressure, like tension, and then they send to the registry. If in case not emergency, if they are emergency, they go to save the life of the patient first, and then they do the registry later on. And then after register, they send the patient to a department, whether they go to IPD or go to OPD. Yeah, and then the patient will need to pass by the payment counter, which number 1 here. We can refer to the user charge. Patient need to pay the user fee. Number 2, people need to know they get the free healthcare by supporting from the Health Equity Fund, also getting some non-medical benefit. And they got a paper from the Health Equity Fund officer, which tell them about how much does the Health Equity Fund pay for them in terms of health service fee and the non-medical cost. So when the patient discharged, they got a piece of paper from the Health Equity Fund officer to tell them how much do they pay for them totally. And then they got to pass a pharmacy to get some medicine to further use, then exit hospital. Next. This is a function and health center. It's not much different from the hospital, but it be short because the health center is a front line to provide primary healthcare services. Yes, it starts with the OD director who do the register for health facility, whether it is a health center or the former district hospital, FDH. And then they do when it come to a health center, director or staff of the health center, they do the patient admission by doing the register, search, and then admission. Whether they go for OPD or whether they go for delivery, and the cashier also provide some benefit conditionally to the delivery. For example, they can get the travel expense. And last, they do the discharge, which follow the ICD-10 diagnosis. This is a picture of flow of patient at the health center. It's starting from normally there's no triage in the health center. People come directly and do the register, and then after register, they do second. They go for the specific health needed, whether they do the OPD, consultation, outpatient consultation, delivery, vaccination, or whatever the service are available at the health center. And then they go back to the number 3. It's about entry the information into the PMRS, and then payment to the health facility if it's not covered by Health Equity Fund. If it is covered by Health Equity Fund, they will get for non-medical benefit if they are doing the delivery, and then discharge, get the medicine from the health center for the use. Next, please. This is about the claim. I think you have should have aware of this slide from the previous event. Yes, the facility need to submit monthly claim for their reimbursement from the Health Equity Fund. It starts from the accountant of the facility. They need to prepare or produce an invoice, and then they submit to the director, for review and feedback. If there is no problem, they approve. They can send to the PCA, and then when PCA receive the invoice from facility, PCA have a role to follow up the submission of the facility, because we divide the date, number of day, which day should they submit to. So we always follow up that to avoid the late submission. We do the review, verify, and certify. We follow up the submission certification from TO, and then we produce the invoice for the Department of Budget and Finance to make for the reimbursement to health facility. And lastly, the Department of Budget and Finance, after receive the invoice from PCA, they also do the review. If there is something wrong or doubt, they send the feedback to PCA, and then they prepare the legal paper for reimbursement directly to health facility by banking system. This is a process of using the PMRS in the Payment Certification Agency, PCA. First, the responsible people need to have a close period for the month, which we need to close. We have that schedule to close the period for claiming, which mean not allow the facility to entry or add any information after closing period. Second step, the facility will produce the invoice, and then invoice will submit to the PCA by their supervisor, which I mean refer to director of hospital or the director of operational district for the health center. And then when the invoice arrive at the level of PCA, PCA will do the review, verify and certify. And then the finance people at the PCA will generate the invoice and submit for approval from the management of PCA, then send to the Department of Budget and Finance, and Budget and Finance will do their job according to the role, like review or produce the legal framework, and then make reimbursement to the health facility. Yeah, next please. Lastly, this is a PMRS accomplishment. We regard it is online digital health system used nationwide by the public health facility for the purpose of health equity fund management, I would say, so far. It is an efficient ICT system for claim verification and certification, because no more paper use for claiming for reimbursement from the Health Equity Fund. And we adopt the International Disease Classification ICD-10 code. It already exists in the PMRS system. We use the standardized health facility code, the same as the health information management or health management information system. And PCA have capacity and able to exchange information with other applications through the API. This is the coverage so far of the PMRS. I would say PMRS the Health Equity Fund nationwide implementation by all public health facility in Cambodia, starting from national hospital, provincial, district hospital, and health center. Totally 1,331 health facility. While the full PMRS so far cover about 285, and it is hoped that after next 2 years we will have 100% of the health center implement the full PMRS, because we have the expanded plan already supporting by the from AeHIN phase 2. I end my presentation with the picture, which this not yet end. This is a free hotline support in case patient of health facility who acquire information about the Health Equity Fund implementation. They can contact our hotline free of charge, 1233, and then through telephone during working day and working hour. I end my presentation with the final slide, which I do the mapping about the current status of overall health information in Cambodia. As you see from this slide, a lot of data a lot of database which getting their own specific information for their own purposes. I would say this is very fragmented information. Even our PMRS, the red circle, you see, we can use API connection only with the data for the poor from the Ministry of Planning only, not yet with other. But we hope we are ready to let our PMRS talk with other system if they are ready to do so. So you see a lot of challenge that Ministry of Health in Cambodia need to integrate or consolidate all these database to ensure that all can talk to each other and can share information among each other. So I end my presentation here. Thank you very much for your attention, and I'm looking forward to have a discussion with you all. Thank you.
Thank you very much, Dr. Chun and Ms. Savatana. So for the first question, we have, does Cambodia have a national ID system, and is this ID being used by the PCA?
Yes, we have the ID system, and the ID is been used for the our targeted population under Health Equity Fund scheme.
Thank you, Dr. Ross. Our next question is, how many % of hospitals taking care of the poor are already using PMRS?
According to this data I show you, all hospital being use the PMRS to manage the Health Equity Fund information in their hospital.
And then the next question, Dr. Ross, is the question is, how many days are there on average between patient discharge and receipt of reimbursement?
I think we do the retro payment. It take less than 20 days. Maybe I would clarify the way reimbursement is made. It is monthly reimbursement claim from hospital or health center. So the claim is lump sum by case. No, it's not individual case by patient. It's a lump sum. So we receive the lump sum invoice from the health facility, and then we do the direct reimbursement to the individual health facility according to the approved invoice issued by the PCA and Department of Budget and Finance. I would say less than 20 days after invoice received.
Yes, thank you for the clarification, Dr. Ross. Our next question is, with the number of stakeholders involved to make HEF successful, how do they coordinate their activities and decision making?
Okay. Yes, we acknowledge the stakeholder contribute direct and indirect for the successful implementation of the Health Equity Fund. However, because of the COVID-19, as everyone aware of that, some function of the stakeholder, it's not really active. For example, one of the key stakeholder to strengthen the governance of the Health Equity Fund implementation, we call the Health Financing Steering Committee at the provincial and operational district level. So it's not well function during the COVID-19. So we miss some solution about the negative finding from the our PGA field staff that supposed to be so during the health finance steering committee, and the rest we are working closely with relating to the target population about the people or department of pre-identification of the Ministry of Planning. We work closely with our Ministry of Economic and Finance, because the governance board of the PGA is a representative from the Ministry of Economic and Finance, being the chairman of the board. And we work closely and report directly to the Minister of Health. And we do the regular supervision or site visit from the central level to the health facility. We also have our field staff who base at the facility to do the monitoring, like doing the document review and household interview. Am I answering the question?
Yes, thank you, Dr. Ross. We also have another question from Dr. Yins. Are some claims checked automatically or all by staff members?
We just recently develop, or we do the re-architecture of the our PMRS system, which focusing to strengthen the claiming system. In that, we develop what we call the auto fraud prevention and auto fraud detection. So some information could be detected or prevented by the system. But of course, claim need to be reviewed by people at the end.
Thank you, Dr. Ross. Are there any other questions from our participants? You may enter them in the chat box or you can ask through the mic.
Cha.
Yes, Dr. Alvin.
Good evening, Dr. Ross. Thank you very much for your great presentation. We learned a lot about the PMRS. We've been hearing about PMRS ever since we've been visiting Cambodia. So we are very impressed with the scope that PMRS has been able to reach. You presented a slide earlier where you showed the different information systems that are being used right now in Cambodia, and PMRS was just one of those the applications and circles. Yes, that's the one. So Vatana. And you also mentioned earlier in one of your slides that PMRS is using an API. Is there a plan in the future for all of these fragmented systems to later on connect to a central national API system? Is that somewhere in the roadmap of Cambodia? Over.
Thank you. I expected that there must be a question when they see this slide. So, good question. I would say, in terms of legal framework, we have two documents which talking about the consolidation and how to say in technical word, in interoperable or something like that. Yeah.
Yes.
One, it is a master plan of health management information system, which have a purpose to let all the system or to delete or develop existing to allow this different database can or able to talk to each other through API. Second, we have the digital, how to say, digital strategy plan, yeah, by MOH, which are very detailed about the roadmap and where to start and how can they bring all the existing into a digitalized context to manage the health information system in Cambodia. To me, as far as I concern and involved in the discussion, MOH now is keen to develop the EMR to be used by the hospital. And as the management of the PMRS, our system is ready to talk with any system through API. For example, as soon as the EMR is developed and used by the hospital, we can generate information from that EMR into our PMRS through API. So our side is ready, but we wait for the MOA to do the digitalized health system. Thank you, sir.
Thank you, Dr. Ross. Dr. Ross, we'd like to invite you to be part of our open emails together with Sobatana, because I think there's a lot of experience that you have right now with the Health Equity Fund. So I will send that invitation to Ms. Sobatana. Thank you very much for joining us in this call.
Thank you, sir. Nice to meet you. My pleasure.
Yes, thank you, Dr. Alvin and Dr. Ross, and also to all our participants for joining tonight's webinar. I would also like to invite you to join us on Friday. We have a specially scheduled webinar at 3 p.m. Manila time, so we'll be using the same room. So we hope you can join us again by then. We'll also send a reminder email. Thank you, everyone.
The topic chat for 3
Yes,
p.m.
FOSS for Governments, Dr. Alvin.
Open source for government. Thank you.
Open source. Yeah.
Thank you, everyone.
Thank you.
Thank you. Good night.